Good afternoon and thank you for the invitation to attend today's public hearing. I would like to make a brief opening statement, as you will already have heard in detail from our Chief Executive, Mairead McAlinden, whenever she attended the inquiry last Wednesday. Without repeating too much of what Mairead said last week, I think it is worth highlighting just a few facts in relation to the population that we serve in the southern area. We have a population of in the region of 360,000. We have the largest ethnic minority population. We have the largest population of people who are under the age of 19, and we also have the largest growing older population as well. Many of the staff who work in the southern area live in the southern area, and I am one of them. The role of the Trust is to provide good health and social care, both to the patients, but also to the staff who have to deliver those services. My colleagues and I attend an inquiry today, as you have heard, all work in acute services and play a lead role in the delivery of our emergency care services. When we come to work each day, we strive to provide good quality care for our patients. And by that I mean we focus on safe and timely care, treating people fairly with dignity and respect, remembering at all times that patients are different, but we also support each other whenever the service comes under pressure. And most importantly, we try to listen to the patients and the staff and try to learn when things go wrong. We do many things well in the southern area, in our emergency departments and our minor injury units, across our wards and supporting services in the hospital, through our patient flow team and with our colleagues in the community. Do we always get it right? No, we don't. And I would like to personally apologise to anyone who has had a poor experience of our service. As an assistant director, I read all the compliments that we receive, but I also read all the complaints. So I am clear that we still have a lot to do to improve our service, but I am confident that we have the commitment of all our staff to do just that. During today's session, I'm sure you'll hear some examples of projects that we have progressed to try to improve our service. I know, Commissioner Reynolds, whenever you visited the emergency department in Craigavon, you will have seen some of those at first hand. Projects such as the implementation of a 60-minute plan to try to focus on quality, not just a 4 and a 12-hour issue, but real quality based on the College of Emergency Medicine standards. Working with our consultant physicians particularly, recognising that a major determinant in terms of ED is outflow. So the work we've done to create a new model for acute medicine in Craigavon Hospital as well is a significant project. I think it's key to say the strength of these projects is that they have been driven by frontline staff and have been put together based on their ideas about what will work. Myself as a manager, it's my job to move that forward on their behalf and to support them to do that. But equally, feedback from patients, their relatives and carers have also shaped those developments. Our Chief Executive said last week, whenever she attended the inquiry, that our emergency departments are a barometer of the care across the hospital system. I totally agree. Every morning I make a point of calling into the emergency department to see how things have been overnight, to chat with the staff and to see if any immediate actions need to be taken. This hands-on approach is maintained throughout the day and every day, and that also goes into the out-of-hours period where myself and colleagues like Mary have a significant role in terms of our on-call requirements.
I can give you one more minute.
Okay. In the southern area, we understand that our staff are our greatest asset. We are very fortunate to have excellent staff who are committed to providing good quality services. We also work very closely with our colleagues in the staff side organisations, RCN, NIPSA, Unison, where regular meetings are held. And that is also helpful in trying to pick up any issues on the ground at an early stage. We do try to listen to what our patients say and what our staff say to try to improve our services. And I think that's one of our strengths. I would like to conclude by recognising the ongoing commitment of the staff who work in the area in order to try to make the emergency departments as efficient as they can be. I would also like to thank any patients and members of the population who have inputted into this process. We are very clear in the southern area that the emergency departments are not islands. They are dependent upon good flow and collaborative working across the system. So we welcome the opportunity to speak to you today, to give you the operational perspective of some of the things that we've done in the southern area. And we look forward to seeing your report when it's published in the spring, and to take forward any other items of learning from that. Thank you.
Okay. Brian, thank you very much. I'm going to kick off with 2 or 3 questions before we get to the initiatives. My first question really is, you said that you read all the compliments and the complaints. So can you tell us what you think the Trust does well, based on the compliments you get, and what the Trust could do a lot better, based on the complaints that you get?
Yeah. Well, personally, I have been involved in working with the colleagues in the emergency department really since 2005. I would say back then our focus was on trying to deal with a significant trolley weight problem, as it was classified, and that in turn had led on into the establishment of the 4 and 12 hour standards through priorities for action. I think we do that very well in the southern area. You may have seen our performance in relation to the 12-hour standard, for example. But certainly our more recent work through our 60-minute plan, our plan has focused on quality. And what we're really trying to do now is to focus on the college standards around triage and streaming and better communications with the patients as they come through the system. Focusing in on things like pain relief, for example, that is a theme that we have picked up through our complaints process and the feedback with staff, and we have incorporated new arrangements for administration of pain relief into our 60-minute plan through triage. So we are starting now to put things in place that have a much more robust means of monitoring how you're doing against quality. I think previously that focus may have been more on the quantitative side, so I would like us to do more in relation to the qualitative side and have that embedded into what we do across our emergency departments.
Okay, and just in terms of a bit more about, on the basis of the kind of having looked at the complaints, what are the areas that you think you could do better based on what you've seen in the trends and the kind of issues that come up again and again?
Yeah. Well, there's we're all mindful of the financial climate and the difficulties that brings. What we're finding now is the emergency departments are busy 7 days a week and increasingly busy during the out of hours period. We do try to manage the resources that we have as best we can. More recently, we have moved to strengthen our nursing cover during the out of hours period, and very recently to enhance our medical cover during the out of hours period. But some of those decisions have been taken internally within the Trust, and we're currently having discussions with the Commissioner about how we could have some of those initiatives funded on a recurrent basis. So I think we need to do that better. One of the other things that I think we need to do better as well as a sort of a health economy in the southern area is to try to have better means of access to patients who require treatments or admission. And we are doing that through, for example, our work with our acute physicians trying to create alternatives rather than the emergency department. Sometimes patients have to default through the emergency department system. So I think we need to get better at providing those alternatives, and we are doing that, certainly in the more recent work we've done.
Okay, thank you. I want to now turn to some of the initiatives that we'd heard about when we were in Newry last week, and I think there are 2 in particular. The first was the idea of a much more holistic approach of joining up medical care in the emergency department with social care needs of patients, so that there was a more effective outflow. And I wonder if you'd say a little bit more about that work and how it works in practice in Craigavon. And the second initiative was the much more joined up approach of the hospitals in the Southern Area Trust, knowing where the pressures were at any one time, and being able to divert people from one hospital to another, and again, just how that's working in practice.
Okay. Do you want to take that one, Mary?
Yes, well, when we actually looked at our complaints, some of the themes that were coming through was poor communication to the patients and also our waiting times. So we sat down and we talked with the key staff within our emergency departments, and we used a multidisciplinary team approach. And we focused particularly on the quality indicators and those areas that we were not doing well in. And from that, we actually sat down and we process mapped the patient's journey throughout the emergency department. And we had our admin and clerical staff there. We had our consultants, our band 3s, our band 5s, our pharmacists, our physio. And we were all able to identify by walking the patient's journey of where the blockages were. And from that, we come up with a quality improvement plan for our emergency department. And the first thing we looked at was when the patient arrives at reception. And we looked at our triage standard, which was not good. It was sitting at around 60%. And we looked at putting in a second triage nurse from 11 a.m. to 11 p.m. We also looked at streamlining the patients at the front door. The triage nurse would be able to look quickly at the flimsy and say, this patient needs to go to minor injuries, this patient needs to go to see the EMP, or this patient looks quite ill, needs to go on down to majors. In addition to that, we also found that some of the patients were being triaged and then went back out into the waiting room. And within our emergency department, we have 60% of our nursing staff are quite junior at the moment. So the consultants actually devised guidelines for staff so that they would know what the frontline investigations were. So we looked at frontline investigations, 2 nurses in triage, the streamlining of patients. Because we have such junior staff, we looked at putting additional clinical sisters, bringing them into posts, so that would be one overall in charge of the department, but also there would also be one working very closely with our junior staff, providing them with additional support and supervision. We also looked at how the department was being managed, and we have now a new approach whereby the consultant and the sister in charge of the department does walk-arounds at different times throughout the day. Now, when we started, we thought we would do it nearly every 2 hours. We realised that wasn't sustainable, so we looked at specific times, and then when we find that the department is coming under pressure, then we will up those walk-arounds. So together, the senior nurse and the senior consultant on charge that day will take responsibility for the management of the floor. I talked about our junior nursing staff, so I'm putting in that additional the additional support. As well as that, we had only 2 nurses in resus, and that's not enough. We've got 5 spaces in our resus. A lot of the time, our resus is filled. We've got evidence to show that the acuity of our patients has increased, and so we looked to put additional nursing staff into our resus area. As well as looking at triage at the front door, we looked at triage, ambulance triage as well, because once again, we weren't happy where we were sitting in relation to that. So we put in ambulance triage and give that nurse a runner with them so that they could start undertaking frontline investigations. And we started that in the 1st of August. And we are actually working with an outside company, Armagh, who actually are monitoring those quality indicators for us. And we do have evidence to show that our triage standard has come up to 90%, and some days it's over 90%. Decision to admit has increased also. The number of patients leaving the department without being seen has decreased. Our complaints have decreased. Our incident forms in relation to staffing, which our nursing staff would have completed in the past, has also increased, or has also decreased. And the staff on the ground, we've actually met with them 2 weeks ago to get feedback, and the junior staff are telling us that they feel very supported. As well as that, our senior staff, because we have a second clinical sister on, they also feel they're more supported as well. And the fact that the medical and nursing staff are working together to manage that department is making such a difference on the floor and to the team.
Okay, thank you. Just two very quick questions. So this has only just started in the 1st of August this year, so it's clearly very, very early days, and that does seem very positive. Is this an initiative across all of the hospitals in the Southern Trust area? It's not just confined to Craigavon. Is this Daisy Hill as well and elsewhere, or is this a Craigavon specific
Well, the initial focus is on Craigavon. However, in the past 2 weeks, we have been rolling that process out to include Daisy Hill Emergency Department as well, taking exactly the same focus as we had. You had asked, Chair, in relation to how we manage across our network of acute hospitals in the southern area, and I think it's unique, the approach that we take in relation to that. And I suppose the way I would describe it simply would be that we, on a daily basis, try to take a proactive approach in terms of understanding where we are across both our acute hospitals but also our non-acute hospitals. We look at the activity, we look at the projected bed availability later in the day, and we understand the typical demand we see. So we work closely, for example, with our colleagues in the ambulance service to try to manage some of the inflow to the hospital. So we work, for example, looking at our GP urgent workload that comes in through the ambulance service, and where it is reasonable to ask patients, for example, who live a similar distance from Craigavon as they do from Daisy Hill, and if we're projecting more capacity, for example, in Craigavon or Daisy Hill, we try to work with our colleagues in the ambulance service and in primary care to flow that activity and get those patients to go in that direction. Because if we do that, there's the potential for those patients to have a more positive experience and a shorter wait. So that's the approach that we have taken in this area, and I know in recent months some information has been published in Northern Ireland showing the number of internal diverts within trusts. And within the Southern Trust, our figure was much higher, but it's much higher because we proactively take those steps to manage that activity to try to prevent pressure points within the system.
Okay, I want just final one before I get to my third question. The idea of a more seamless approach between the social care side and the healthcare side, can you just tell us exactly what that means in practice?
Can I come in, maybe, Chair? I think maybe I'll just highlight the case of some of our elderly care patients. I think that Barry has mentioned it's very important. The non-acute hospital sites, such as Lurgan Hospital, access to that is from several different streams. So in the emergency department, from our short stay ward, we work closely with our geriatric liaison team. It involves both a doctor, a physiotherapist, an occupational therapist, and a social worker. So they may be able to go home with additional support. They may need to go to Lurgan Hospital, which is our geriatricians work on both the Craigavon site and Lurgan site. And so that's that seamless care from the emergency department through short stay ward and then through to Lurgan. So if someone doesn't need to be in an acute setting, there's that step down before they need to go home where they kind of continue care. So I think we realise how important that is, and we're able to access that from day to day. I think that's one example how we know across all the sites we're working together, just using that example of the elderly care person. You did mention about transferring between and diverting between hospitals. As clinicians, maybe say that's something that is usually last minute and bad practice in terms of the emergency department in Daisy Hill is overcrowded or in Craigavon. Let's send people to Daisy Hill. That's something we will try to prevent happening. So if we know that it's busy overnight in the emergency department in Craigavon, we know in the morning we have to make some capacity, or come the evening it will be overcrowded. Bypassing and diverting patients usually just leads to delaying the inevitable. The other department will be overcrowded in 24 hours time, so we try to prevent that from happening.
Okay. My final question, very quick one. We've heard evidence both last week and today that in terms of issues of bullying and that those are issues. And last week we heard very much it was across the piece. Today we've heard there's room for improvement in dealing with that, and it's worse in some trusts than others. Is that an issue for you in the Southern Trust? And if so, how are you dealing with it?
I would say from a nursing point of view, it's not an issue. I personally don't feel I have a very good nursing team, and although a lot of them are very junior, I think the relationship that I have with them and the medical staff and the managers have with them is actually a very good one. I don't know, maybe because we're a smaller hospital, and we do, as I say, we all live around that area and work together, we socialise together. I don't, from the nursing point of view, I wouldn't say it was an issue.
I think part of it is about valuing your staff. And, I think, at all levels, we do lead by example. We are on the floor. We could be in the emergency department 3 times before 9 o'clock in the morning, just trying to support staff, especially in the mornings when we come in and they're under pressure. But I think, as well as that, we also recognise that everyone has an important role to play, from the domestic that's out there in at 6 o'clock in the morning, cleaning floors, right through to our consultants. So everyone has a very valuable role, and it's recognising and respecting that role. We have very good communication systems in place within the emergency department. We have our ED specialty meetings, which is with our consultants and nursing staff monthly. Sharon has her meetings with her staff. I go to them, and also with her clinical sisters, which I would also attend as well. And we encourage staff. Staff will stop me and they will ask me, or they'll say to me, I have an interest in this, and they will, they'll say to Sharon, and we'll have that discussion. And so we do listen to staff, and we do respond to the staff. I think, as well as that, we want highly qualified, highly skilled, confident and competent staff within our emergency department, and we're absolutely committed to that. And we know that we're under financial constraints, but we send staff to our commission courses. We use in-house training. We have got a nurse that has been, and I think it's the only nurse I'm aware of in Northern Ireland that has been properly trained as a Manchester triage nurse trainer. And at the minute she has over 90% of our nursing staff trained in the Manchester triage, which is a great achievement for her. A lot of the learning happens on the floor, so we depend. There is medical and nursing staff where the medical staff will teach and they learn together. And then we also have our monthly M&M, which management and consultants and the MD, and we even have our band 5s going to those M&Ms as well, because that is part of how we learn as well.
I think for our medical staff, the majority of my medical staff are trainee medical staff, and there's robust and repeatable anonymous mechanisms for reporting bullying in the workplace. For the permanent member staff, there are the trust mechanisms for reporting bullying, but I do not think there's a culture of bullying. We welcome the 4-hour performance. We welcome that when it came into place in 2007-8, and it is a marker of care, and it should be encouraged, but we're encouraged to provide quality of care, with the 4-hour target being part of quality, not a target to be reached at all costs. That has never been our culture or our attitude.
This is an observation, and I'll pass you to Marion, but I have been struck by, the difference between some of the evidence we've had, if you like, from the shop floor, so to speak, and through the staff and trade union side, and not confined to the Southern Trust, some of the evidence we've had that the issue, this is an issue, and people work under pressure, and the difficulties people face, and there are reluctance to report bad practice or to feel involved in processes or to offer criticism, and a kind of management side that's been saying, well, actually, no, this is not a major issue. Really, observation of why there's such a disconnect, and you may not want to answer that at all, but there is clearly a disconnect between those two sets of evidence.
I suppose what in my opening statement I had tried to underline the sort of the hands-on approach that we take, and I certainly would encourage any member of staff to approach me, and regularly they do, and they're not shy about coming and bringing issues to me, nor is Sharon or any of the other staff, and I welcome that. And equally, if staff feel that they're not able to do that, there's other means of them making contact with me or linking in with their staff side representative, and I have regular meetings with them as well. So I would be confident enough to say that certainly in my experience, the relationships with the staff are very good. There is a real team approach, and we support each other every day in what we do.
Okay, thank you. I'm going to pass you to Marion because I'm very conscious of time here, so sorry to cut you off there. Mary.
You're pleased to know I've only one question. Barry, you've already mentioned when you were doing the demographic profile of the Southern Trust, its high migrant population and its high population of under 19s, and Mary, you've talked about the ED journey. And I'm wondering, could you outline the ED journey for those two groups of patients and your assessment of how well that is operating across the Southern Trust Hospital?
Can I just clarify the two patient groups, please? I just didn't hear you. Which two patient groups do you want us to identify?
Migrants and children.
Okay. Do you want to maybe take one each? Do you want to do children and Sharon do migrants?
I'm going to take the migrant population. I think for the migrant population, the first thing they do when they come in is they register at the front desk. That obviously has its initial hurdles. Some of our community groups will have, who are more established in particular, will have organised social workers, translators for them. Think of the Chinese community. They then have to be triaged and given an appropriate urgency category, and then they will go through and come and see a doctor or nurse. At any stage we can access language line, or the big word, and have a translator so they can translate over the phone. That is difficult sometimes where we have to, we're usually very speedy and quick to that, but you usually have to access it several times. Maybe you need to meet a person, have to order x-ray or a test, and then talk to them again later on. They then may have to receive treatment from a nurse or one of the pharmacy staff, so again we may need to use a translation service several times. I think the sheer volume of languages we encounter makes it difficult to produce lots of posters. We have such a broad spectrum of people from Eastern Europe. In particular, there's one or two countries where they speak Russian but would be highly offended if you say that they were Russian. So I think being aware of that, we've struggled to get a sufficient volume of written information, but we do have at the triage process on the front desk a folder of multiple languages that people can identify and speak to and point, so we can have translation on simple common problems at the front. So that's their journey from start to finish.
Can I add in on discharge? We also have our discharge leaflets, advice leaflets are in different languages, and we keep those all on a shared drive so that if we need them at any time, you can just go and print them off. And that's your head injury advice, crutches, plaster advice, how to access different hospitals, dental clinic, and that's been a bit of work that we've done.
So in general, do you think the system's operating well for your migrant population?
I think sometimes when you prefer an on-site interpreter, and we do have issues with trying to access them, and it's just the process that I think all of that has been agreed through BSO, but generally we do find that if we need to communicate with them, we can. I think the difficulty is whenever you get someone, perhaps that there's been a death or mental health issues, and that just makes it very difficult and very sensitive issues.
And in relation to children?
Children, we have, I think, we used to have a dedicated children's area. That no longer is used specifically for children. We just find the volume of adults, the walking majors patients as we call them, coming through. We needed somewhere more to see them. So there was work again done with our paediatric colleagues, and they had an ambulatory paediatric unit established where they were then taking some of the children that previously would have come through us. They were taking them up to the ward and being seen there. That It's early days, but we do have pathways there that if someone presents even from the GP, we can lift the phone, and if they fit a certain criteria, they go directly there. They don't have to wait in the emergency department. We have access to CAMS, which is our child and adolescent mental health, and that recently has been extended to 7-day a week. So if we have any children presenting with mental health issues, we can lift the phone again and do a referral to them and get them seen, usually on the same day. I'm trying to think what other paediatric nurse. My paediatric nurses, I try to have a paediatric nurse on shift 24/7, but it's a luxury some days. And I do with all my paediatric nurses. I have them trained to APLS, and I roll that training out to my other band 5s, because obviously there will be days when I don't have a paediatric nurse on duty.
We have identified with the managers a plan to have a dedicated paediatric area in the future, and that's just we just have to try and get it commissioned and find a small amount of additional money.
So I think we're accepting, Commissioner Reynolds, that the way we currently manage children in terms of the environment could be better, but we have to make do with what we've got for now. We're in the early stages of discussions in relation to a major rebuild for the emergency department in Craigavon. That's likely to take 5 years, to be honest. But we've also identified some more short-term adaptations to our minors area, which could provide a better environment for children. And, for example, a sub-waiting area that's dedicated for children and their relatives would be a positive step forward.
Thank you very much. Thank you.
Paul.
Thanks very much for your help and your time. Can I just try and pick up that last point? I want to make sure I understood it, and maybe I didn't quite catch it, so excuse me. It's in response to Marion's question. I think you said that there are plans to have a paediatric section to your EDs.
Yes.
And then you said, quite properly, that that's subject to commissioning.
Yes.
So just explain as briefly as possible, how that would work. So it's been identified that you wish to have I don't know what the right term is, but a paediatric section to ED. So how does that work in the commissioning process? Just briefly take me through the process and the arguments that would have to be put by whom, where.
I think as a clinician, maybe I'll speak for my section first, we would meet up as clinicians and identify what options we have, what areas we should convert, what ideas we would have, and then we would meet up with our management colleagues to try to facilitate that through the commissioners in terms of how to deliver that process. So I think initially in terms of the ideas, as a clinician, discuss several options, because we always need to have a couple of different options, and then bring forward with the management team to have a business case, and then try and deliver that through the commissioners.
So, and there are regular meetings with management, sort of weekly, monthly or something?
Yes, yeah.
Right, so you take it up there.
And it's not, in particular idea we're talking about, I think we went up with a map and a couple of different diagrams
right.
To our management office and say, listen, these are our ideas, we have had to adjust, this is what we need, let's make this happen. So even outside that formal structure, we were comfortable in meeting up and trying to address that. And
then what happens? Let's say they're persuaded, great idea, right? So then what happens?
And then
that's over to you, Barry.
That's myself and Mary. So we would then,
just briefly. I'm worried about time. But thank you.
We would start to work that up in detail with staff in our planning department within the trust, and as we start to work the detail of that up, I would be in communication with Gareth and his colleagues, and indeed other members of the multidisciplinary team, so that we had a sort of a scheme together. But what I would try to do at an early stage would be to get an early view from the commissioning people as to whether is this likely to happen.
The commissioning people being located where?
The commissioning people would be both in the local commissioners here in Armagh and the regional commissioners in the board. Right. So what I would try to do at an early stage would be to get a sense from them, is this a runner? Because I wouldn't want to have the clinicians, doing too much work. And then if they're given the indication that it is, I would start to work with the detail with colleagues in finance, in contracts, etc., linking with the clinicians regularly until we had a plan agreed, and then that plan would go forward for consideration to the commissioner. And then regular meetings, queries would go back and forth. And that's why that process, as I alluded to earlier, for example, we're at the very start of that process now in relation to a redevelopment of the Craigavon Emergency Department. that could take 5 years to work its way through.
And then, with a bit of luck, there's a service agreement,
Yep.
which would include extra money
Yeah.
for that new facility. Is that right?
Yes.
And then in that service agreement, would there be indicators to measure the fulfilment of that service agreement?
Yeah. So the way that I would, we would have to take into consideration if it's a major redevelopment of that scale, I would work closely with my colleagues in the equality unit within the trust to assess issues around privacy, dignity,
Yeah.
access in terms of the actual accommodation, so that we were confident, and there would have to be sort of an equality impact assessment,
Sure,
etc., carried
sure,
out through that process.
Sure. I suppose and I mustn't take up too long, but thank you. This is helpful for me to understand the sort of. You can read it, but to hear about it from people who are involved in it is quite enlightening. So thank you. I suppose I'm interested in whether or not the service, what role you would have in ensuring that the service agreement has appropriate indicators to catch quality, for instance.
Mm-hmm.
So to what degree are you it's not a trick question, to what degree are you able to discuss what the appropriate indicators would be, so then they possibly aren't just quantitative indicators, they might be qualitative indicators. So what degree can there be a discussion about that sort of thing in the board in relation to the draft service agreement? Am I clear?
Yeah.
Okay.
And to be honest, the way that works is that there are regulations down through the estates and contract system that would dictate the type of accommodation that we should have in terms of sort of the bed spaces, the size treatment rooms should be.
Yeah.
But we have the ability to indicate as to how that would be best set up to enable us to deliver the care, taking into account the patient's perspective. For example, thinking about privacy, whenever you're having conversations with patients, thinking of the different types of patients that come through.
But what I mean, Barry, is when the agreement's been rolled out for a couple of years,
Yes.
there'll be a report back. There'll be the accountability review.
Yeah.
Right. So then they'll be looking at indicators to see how well you've done.
Mm-hmm.
Right. And I'm just wondering whether you are able to influence the indicators that will be used to measure how well you've done. And will those indicators all be numerical, quantitative indicators, or will there be scope for qualitative indicators, talking about dignity and respect, for instance?
Yeah. Well, I suppose there is, in relation to the things that, in terms of the performance and the accountability processes, a lot of that previously has been around the quantitative stuff.
Yes.
And I think what we're trying to sort of communicate to you here today is that locally we are trying to take much more of a qualitative approach to that.
That I've understood.
Yeah.
Thank you. You've been pretty clear about that, and it's most interesting. I'm trying to figure out whether or not your interlocutors in the commissioning board will be sympathetic and responsive to this endeavour to work more on qualitative.
Well, I suppose I would say to date we have found the commissioners to be very supportive in relation to plans that we have taken forward. And I think in the southern area we have built up a good relationship with both the local and regional commissioner over a number of years, and I think they have faith in our ability to deliver. And certainly I'm finding that if we do want to put a more qualitative approach to that, I'm sure our views will be listened to. That certainly has been our experience through the plans that we're looking to bring in around, for example, acute medicine. That's the most recent change, and we are thinking about not just a 4-hour issue and an access issue. We're talking, for example, about the number of times patients have to be moved through their journey. Yeah. That's currently not counted anywhere in the system, but that's one qualitative thing that we have included within.
Can I come in really quickly in that perhaps there isn't, that for example is easy because we realise that's a standard of care that should be there.
Yeah.
Some other services, maybe as a clinician, we get frustrated. Some people come along for the emergency department and say, well, we work in cardiology services. We could develop this service that'll help the emergency department. They'll take these patients away. And we feel there's not maybe accountability for some of those things that get commissioned. It'll help us, but nobody ever has an outcomes measure that's helpful. So somebody, we'll do this, that'll help the emergency department. Yeah. We feel people maybe developing their own service. So yes, maybe there should be more accountability whenever someone is commissioned that is actually doing the thing it says it's going to do. So maybe there isn't that structure in place for everything that is commissioned. Perhaps not.
Because it'll drive you nuts if you're trying to develop something. Yeah. but it doesn't, and it's sort of, what's that cliche? You know, it's a round plug or whatever, but then it's got to fit into a square hole that's being created by the commissioning board. I'm just trying to find out whether there's a incongruity between what you're trying to do and what the commissioning board is expecting you to do. Anyhow, thank you. I think I've probably taken up too long, so I'm going to be much shorter, and I'm going to cut out some questions. The adverse incident reporting process, you'll be very familiar with it. Could you briefly comment on the degree to which the relevant family is engaged in that process? I don't mean are they sitting there throughout, I wouldn't expect that, but to what degree is a relevant family included in the adverse incident reporting process?
Well,
Yeah, they take them.
Okay. Well, I suppose what I would say is that we do have sort of an open culture of reporting of incidents within the trust, and particularly within emergency care. And what we try to do, whenever there is a significant incident that has occurred, we do try to make contact with the family at a very early stage in that process. Obviously, depending on the nature of the incident, we have to be sensitive in terms of how that contact is made. Yeah. But we do try to, and I suppose in the past, certainly in the past couple of years, I think we've got better at that process. So we certainly make contact with the family at an early stage, give them a quick overview of what has occurred, and try to give them a sense of what we plan to do in terms of the investigation and who would be involved. Now, we would be treating that on a sort of case-by-case basis as to what extent the family would wish to be involved. The experience to date is that the vast majority are happy to have been contacted. They want to know how it's going to be investigated. They want to know the time scale, and they want to know when they would be contacted. And again, certainly my experience with the families that I have dealt with is that they want to have a sense of that it would be looked at openly and honestly, and that we would try to, more importantly, get to the learning. And whenever we have gone back to the family and give an overview of the lessons learned and give them an update about what has been done to make things better for the next patient coming through, I think they get some, I think that gives them some relief in terms of lessons have been learned. I think we're getting better at that.
And I think the document's just been changed recently, hasn't it? There's been an addition to the documentation, the process, to try and ensure there is that greater engagement with the family. Okay. Last question, thank you for your patience. It's about this question of openness, which my colleagues have talked about, but I think it's terribly important. And I just wanted to make these brief observations. When I talk about openness, I mean whether or not in your hospitals there's a culture of openness and participation among staff. And I'm just trying to understand the situation. I've heard what you've said. And just briefly, can I, and forgive this indulgence, I'm a lawyer, right? Sorry about that, but there we are. So the legal profession is very hierarchical, okay? So, there are judges, there are senior counsel, there are senior partners, there are assistant solicitors, trading solicitors, legal executives, blah, 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 blah. Okay, now, given that hierarchy within the legal profession, I don't know whether Les would agree with that characterization, but this makes having an open participatory work environment in law quite difficult, because we've got this hierarchy, okay? That's law. Can I now come to your profession? Now, some suggest that the health profession is comparably hierarchical as the legal profession, if not more so, some would say. So I wonder, do you think that one of the difficulties you encounter, it's not a difficulty of your making, I'm just trying to understand difficulties. Do you think that one of the obstacles, one of the difficulties that you encounter in trying to create a culture of open participatory workplace is this sort of historic hierarchical nature of the health profession? Is that one obstacle that you encounter in trying to become more open? Or am I just wrong? I don't mind if you tell me I'm wrong. Just very crisp answers, but what do you think, frankly speaking?
From your perspective, Sharon, from a department manager working with staff,
No, I would say probably the opposite, I think. Well, I think now nurses aren't considered, well, I don't think they're considered as even professionals nowadays. We do get subjected to a lot of abuse, a lot of violence. And I think sometimes people come in and, we do probably, we take a lot of their frustrations and anger that should be probably directed at more other people. Maybe the medical staff, maybe the managers. But
I suppose my perspective of it would be that the engagement of the department and ward managers like Sharon and her staff is key, and it depends on how other parts of the structure go about their business. Some can be hands-off, can manage remotely, but if you take the approach that we have taken in relation to the team approach and the very hands-on approach and supportive approach.
But does that run against the grain of the long, venerable history of health professionals?
I think that sort of is something that has gone many years ago.
It's gone?
Yeah, I do.
Okay, thank you very much.
Okay, Barry and colleagues, thank you.
Thank you.
Same offer we've made to everybody who's given us evidence, which is if you want to provide any additional written material or submissions, we're very happy to take that. So if you want to augment anything you've said today, or you think we missed anything that's important that we hear, please feel free to do that. Thank you for giving up busy time in busy lives in terms of the emergency department and nursing. It's really appreciated, and thanks, that's been really useful for us. So thank you very much indeed.